Okay, let's unpack this. We are about to dive into a pharmacological battlefield that, despite all our modern advances, is still the single leading infectious cause of death worldwide. We're talking tuberculosis.
Right. And it's not just some historical footnote. This is a massive current crisis. It demands, well, immense pharmaceutical sophistication.
Absolutely. And the scale is just staggering when you think about it. A quarter of the entire globe is infected with latent TB infection, LTBI.
That's the essential starting point for, any deep dive like this. It sets the stage. We're grappling with a disease where treatment isn't measured in days or weeks. We're talking months, sometimes years.
And our sources today really detail these rigorous strategies and the specialized drugs needed. The first line, the second line, even those for leprosy, they're all designed to combat the unique sort of shielded nature of these mycobacteria.
Exactly. It's a unique enemy.
So our mission today, for you listening, is really to master this information. We want to understand these treatments like the experts do, recognizing the mechanisms, predicting those tricky adverse effects.
And crucially, connecting the why, the long-term multi-drug regimens, it all ties back to how this particular pathogen behaves. Getting that full context is key.
Success here sounds like a very delicate balancing act.
Oh, it absolutely is. It hinges entirely on anticipating toxicity. Things like optic neuritis or that crippling neuropathy, and navigating potentially catastrophic drug interactions.
All while trying to maintain perfect adherence over 6 months, maybe longer?
Right. It's probably the toughest sustained clinical challenge in infectious disease, honestly.
Okay, so to understand the strategy, we really have to understand the enemy's resilience first. Let's start with part one, the unconventional enemy mycobacteria and the drug resistance challenge.
Sounds good.
So when we talk about mycobacteria, what are we actually looking at? They're rod-shaped aerobic bacilli, but what's the really defining thing?
I think it's their sheer frustrating patience. Their growth is incredibly slow. They only multiply maybe every 18 to 24 hours in a lab setting.
Wow, 18 to 24 hours compared to, say, E. coli, which is like 20 minutes.
Exactly. And this sluggish pace, this slow life cycle, that's the primary immovable constraint. It dictates why treatments have to be so long. You simply can't wipe them out quickly.
And they have this incredible armor too, right?
Yes, that's the other defining feature, the cell wall. It's dominated by these things called mycolic acids. Think of them as long-chain, very fatty, waxy molecules.
Beta-hydroxylated fatty acids, technically.
Right. And they form this thick, waxy, almost impermeable layer around the bacterium. It's like a biological shield.
It's literally a wax coating. And that's where the genus name Mycobacterium comes from, right? The fungus-like waxiness.
Precisely. And it also explains that unique staining property they have. They're acid-fast.
Meaning they don't stain well with the standard gram stain we use for most bacteria?
Correct. Because of that waxy barrier, the gram stains don't penetrate well. But once you do manage to stain them, usually with a harsher stain like carbofuran and heat...
Then they hang on to it stubbornly.
Exactly. They resist decolorization by acidified organic solvents. That clinical characteristic, their acid-fast identity, is absolutely key for diagnosis in the lab.
Okay, so we have this slow-growing, waxy-coated bug. Now let's talk scope. Obviously, M. tuberculosis is the big one, causing latent TB and active TB disease.
Yes, the main target. But the picture is getting more complicated. The sheer scale of non-tuberculous mycobacteria, or NTM, is really growing in frequency. And that complicates treatment strategies quite a bit.
Right, because NTM species are, well, they're a real clinical headache, aren't they? Unlike TB, there aren't specific optimized drug regimens developed just for them. We're sort of repurposing existing tools.
Like exactly it. We're often flying a bit blind, relatively speaking. The key examples you see popping up frequently are the M. avium intracellular complex, or MAC. Then there's M. chelone, M. abscessus, M. kansasi, M. fortuitum. It's quite a diverse group.
And the treatment for these NTMs varies dramatically.
Oh, completely. It depends on the species where the infection is located. But generally, the regimens pull from things like macrolides, rifamycins, aminoglycosides, drugs we'll discuss later.
And we should also briefly mention M. leprae, the cause of leprosy, another mycobacterium requiring its own specific approach.
Yes, needs specific agents like dapsone and clofazimine, which we'll touch on. Still a major global issue, even if less common here.
Okay, so this complexity, this slow growth, it brings us right to the fundamental principle of all antimycobacterial therapy, the challenge of resistance. Why is resistance almost, well, seemingly inevitable if we don't treat perfectly?
It's baked into the biology, unfortunately. Any large population of M. tuberculosis isn't perfectly uniform. It naturally contains a small number, maybe 1 in a million or 1 in 10 million cells, that is spontaneously resistant to any single drug you might throw at it. Just random mutation.
So even before we start treatment, there are already some resistant bugs lurking.
Exactly. Now, if you use just one drug, what happens? You create this intense selective pressure. You efficiently kill off all the susceptible organisms, the vast majority.
Leaving the field wide open for those few pre-existing resistant ones.
Precisely. You've selected for them. They now have no competition, and they flourish, becoming the dominant population. Yeah. The infection comes roaring back, but now it's resistant to the drug you used.
So you're basically breeding superbugs if you use monotherapy. That was seen really early on, wasn't it?
Tragically, yes. The classic example is streptomycin, one of the first TB drugs. When used alone, resistance developed incredibly rapidly, sometimes within just weeks. Those naturally resistant cells were instantly selected for.
Which leads to the absolute cornerstone doctrine of TB treatment.
Non-negotiable. Multi-drug therapy is mandatory for active TB. You must use multiple agents simultaneously. The idea is to hit different targets, different bacterial populations.
So if a bug happens to be resistant to drug A, it'll hopefully still be killed by drug B or C.
That's the principle. The odds of a single organism being spontaneously resistant to 2 or 3 unrelated drugs at the same time are astronomically low. So combination therapy suppresses the emergence of resistance.
Even if the patient starts feeling much better quite quickly.
Especially then. Clinical improvement can happen fast, but that doesn't mean you've eradicated every last bug. You have to continue the multi-drug regimen for the full duration. The goal isn't just temporary suppression, it's complete sterilization to prevent relapse.
Okay, that necessity, the requirement for typically 4 drugs for months, forces us directly into part 2, chemotherapy strategy. We need to talk duration, phasing, and critically adherence.
Right. The logistics are demanding.
Let's start with duration. The clinical commitment here is just enormous. For latent TB, LTBI, the asymptomatic infection, what are the options?
For LTBI, treatment is simpler but still long. The classic option is isoniazid or PHARMACOLOGY, used as monotherapy, but for 9 months.
9 months of single pill daily.
Yes. Or there's a shorter, more intensive option. 12 once-weekly doses of higher-dose INH combined with rifampin. That gets it done in 3 months, which can improve adherence.
Okay, but that's for latent. What about active, drug-susceptible TB?
For active disease, assuming the bug is susceptible to our main drugs, the minimum is 6 months of combined multi-drug therapy.
6 months minimum. And this isn't just 6 months of the same thing, right? It's broken down into phases.
Correct. 2 very distinct phases, designed strategically to tackle different populations of the organism over time.
This is the standard short course regimen, often abbreviated RIPE for the drugs involved. Let's talk about the first phase, the intensive phase.
Okay, the first 2 months are the intensive phase. This uses all 4 of the first-line drugs: isoniazid, INH, rifampin, RIF, pyrazinamide, PZA, and ethambutol, EMB, RIPE.
4 drugs for 2 months. What's the strategic goal here?
The goal is rapid kill. You want to knock down the bacterial load as quickly as possible, especially the actively replicating extracellular organisms. You also want to hit the bugs hiding inside macrophages and in those acidic pockets within lesions.
So it's about reducing the total number of bacteria fast and making the patient non-contagious quickly.
Exactly. And that 4-drug punch, right at the start, aims to immediately suppress any potential emergence of spontaneous resistance to any one drug.
Okay, so after that initial 2-month 4-drug assault.
Then we transition to the continuation phase. This typically lasts for the remaining 4 months.
And the regimen changes.
Yes, it's usually downgraded to just 2 drugs, isoniazid and rifampin.
So RIPE for 2 months, then just RI for 4 months, making 6 months total. What's the job of this longer 2-drug phase?
This phase is crucial for preventing relapse. Its job is to clear out the remaining persister organisms. These are the slow-growing or dormant bugs hiding deep in those granulomas or other difficult-to-reach sites. They're harder to kill, hence the longer duration needed.
Got it. And I assume these regimens can be tailored.
Oh, definitely.
Oh.
Once you get susceptibility testing results back from the lab, which can take weeks, you adjust. For instance, if the isolate is confirmed susceptible to INH and rifampin.
Then maybe you don't need the ethambutol anymore.
Exactly. Ethambutol is primarily included up front as a safeguard against potential INH resistance.
Yeah.
If you know INH is working, EMB can often be safely discontinued early, maybe even after the first few weeks or the 2-month mark. PZA is almost always stopped after 2 months anyway.
That's the plan for susceptible TB. But the reality hits hard when we face drug resistance. Multidrug resistant TB, MDR-TB, that's resistance to at least INH and rifampin, are two best drugs.
Right. And when that happens, that standard 6-month timeline just goes out the window.
It explodes, doesn't it?
Mhm.
How long are we talking then?
For MDR-TB, treatment typically lasts for about 2 years, sometimes 18 months, sometimes longer, but think 2 years on average.
2 years? That's unimaginable.
It's a massive physical, psychological, and logistical burden for the patient. Adherence becomes incredibly difficult, patient burnout is high, and the regimens themselves are profoundly more toxic. We have to bring out the second-line agents.
What does that 2-year MDR-TB cocktail generally involve? What are these second-line drugs?
We have to build a whole new regimen from the ground up, usually aiming for at least 4 to 5 drugs that the isolate is still susceptible to. This typically involves an injectable agent like an aminoglycoside, say amikacin or maybe capreomycin.
Injectable, so daily or weekly shots for potentially 2 years.
Often, yes, at least for the initial intensive phase, which might be 6 to 8 months. Then you add a fluoroquinolone like levofloxacin or moxifloxacin. These are critical for MDR.
Okay, injectable, fluoroquinolone, what else?
Then you stack on any remaining active first-line drugs, if any, maybe PZFs or ethambutol are still effective. And you add one or more other agents like cycloserine, ethionamide, or maybe paraminosalcilic acid, PAS. It's a complex, often poorly tolerated mix.
And then there's the worst-case scenario. Extensively drug-resistant PB, XDR-TB.
Right, that's MDR-TB, resistant to INH and RIF, plus resistance to any fluoroquinolone, and resistance to at least one of the second-line injectable agents.
So you've lost your best first-line drugs, your best quinolone, and one of your key injectable backups. What's left?
At that point, treatment becomes truly empirical, almost desperate. You're scrambling to find any combination that might work. You might be using drugs like clofazimine, maybe lanazolid, agents with extremely high toxicity profiles.
It sounds like you're weighing severe known toxicity against near-certain death without treatment.
That's exactly the calculation.
Yeah.
It's incredibly difficult.
This all brings us inescapably to the clinical tightrope walk of adherence. Asking patients to take a complex cocktail of pills, maybe injections, for months or often years, low adherence seems almost guaranteed without intervention.
It's a huge problem. And poor adherence doesn't just risk treatment failure for the individual. It actively drives the amplification of further drug resistance in the community. It prolongs the crisis.
So how do public health systems try to tackle this?
The most effective strategy, particularly in high-burden settings, is directly observed therapy, or DOT.
DOT. It sounds a bit paternalistic, maybe.
It can feel that way, but the evidence is overwhelming. It's a non-negotiable success strategy in many places. The mechanism is simple. A healthcare worker, or sometimes a trained community member, physically watches the patient swallow every single dose of their medication.
Every dose, every day.
Ideally, yes, or several times a week, depending on the regimen. The logistics can be challenging, no doubt, especially in resource-limited areas. You need staff, transportation, patient tracking.
But the results justify the effort.
Undeniably. DOT significantly decreases the emergence of acquired drug resistance during treatment, and it measurably improves cure rates. It often makes the difference between success and catastrophic relapse with even worse resistance. It basically turns a theoretical regimen on paper into a guaranteed clinical reality for that patient.
Okay. That strategic overview is crucial. Now let's transition into part 3. This is where it gets really interesting, I think, drilling down on the unique pharmacology of that first-line arsenal. We need to understand exactly how these 4 agents, RIPE, work together.
Right, the nuts and bolts of each drug.
Let's start with isoniazid, INH. It's the cornerstone, really. Why is it so effective, but also why is resistance to it relatively common?
Well, the secret to its effectiveness and the risk of resistance are actually linked. INH is a prodrug.
Meaning it's inactive when you take it.
Exactly. It's inert until the mycobacterium itself activates it. There's a specific mycobacterial enzyme, a catalase peroxidase called CatG, that does the activation step.
So the bug activates the weapon used against it? That seems like a design flaw for the bug.
It is. But it also presents an easy escape route. If the bacterium has a mutation in the CatG gene or deletes it,
then it can't activate the INH and the drug becomes useless.
Precisely. That loss or mutation of CatG is the most common mechanism of high-level INH resistance.
Okay, so assuming CatG does activate it, what does the active form of INH actually do? What's its target?
The active metabolite covalently binds to and inhibits 2 key enzymes in the bug, in ARI, which is an acyl carrier protein reductase, and CASA, a beta-ketosyl ACP synthase.
And what do those enzymes normally do?
They are absolutely critical for building the mycolic acids. They're essential steps in synthesizing those long, waxy chains that make up the cell wall.
So INH effectively stops the bug from building its protective armor.
Exactly. It disrupts cell wall synthesis, leading to bacterial death. It's highly bactericidal, especially against actively growing organisms. And it also works well against bacteria hiding inside macrophages.
And the other resistance mechanisms relate to this pathway too.
Yes. Besides CAG mutations, you can also get mutations in the target enzymes themselves, like varying mutations in the acyl carrier proteins, or, and this is important, overexpression of the target enzyme NAA.
Overexpression, meaning the bug just makes way more NAA enzyme.
Right. So much that the standard dose of INH can't inhibit it all. This often leads to low-level resistance, and it's clinically relevant because it can cause cross-resistance with another drug, ethambutol, which also targets mycolic acid synthesis, albeit slightly differently.
Interesting. Okay, let's talk pharmacokinetics, PK. How the body handles INH, because there's a really important genetic component here, isn't there?
Absolutely crucial. INH is usually well absorbed orally, though taking it with food, especially high-fat meals, can reduce absorption, so taking it on an empty stomach is generally recommended.
And gets everywhere.
Pretty much. It distributes really well into all body fluids, into cells, even into that cheesy necrotic stuff you find in TB lesions called caseous material. It gets into the cerebrospinal fluid, CSF too, with concentrations similar to what's in the blood, which is good for TB meningitis.
But the metabolism, that's where genetics comes in.
Yes. INH is primarily metabolized in the liver by a process called N-acetylation, which creates inactive products. And the enzyme responsible for this, N-acetyltransferase 2, or NET2, has genetically determined variations in its activity.
This creates the famous acylator divide.
Correct. Based on their NAT2 genetics, people are generally categorized as either fast acetylators or slow acetylators.
What's the difference in practice?
Fast acetylators metabolize INH very quickly. Their serum half-life for the drug might only be about 90 minutes. Slow acetylators metabolize it much more slowly. Their half-life is significantly longer, maybe 3 to 4 hours. They end up with higher overall exposure to the parent drug.
And does this matter clinically?
It definitely can. Slow acetylators tend to have higher rates of certain dose-dependent toxicities, particularly peripheral neuropathy and potentially liver toxicity, because they're exposed to higher drug levels for longer. Fast acetylation is more common in some populations, like East Asians and Inuit peoples, while slow acetylation is more common in others, like Europeans and Africans. It's a classic pharmacogenetic interaction.
Okay, speaking of toxicity, let's get into the adverse effects. The most serious one is hepatitis, right? Liver damage.
Yes, INH-induced hepatitis is the biggest worry. It can range from mild elevations in liver enzymes, which happens in maybe 10–20% of patients, and often resolves even if you continue the drug, to severe, potentially fatal hepatitis if the drug isn't stopped promptly when symptoms occur.
What increases the risk?
The risk goes up significantly with age, especially for people over 35. Taking it along with rifampin also increases the risk, as does daily alcohol consumption. Regular liver function monitoring, especially early in treatment and in high-risk individuals, is essential.
Okay, hepatitis is the big one. What's the second critical side effect?
Peripheral neuropathy. This usually manifests as numbness, tingling, or burning pain in the hands and feet, paresthesias.
And this leads to that absolutely critical yet simple co-intervention that everyone prescribing INH needs to know.
Right. The neuropathy is caused because INH interferes with the metabolism of pyridoxine, which is vitamin B6. It essentially creates a relative B6 deficiency.
Which is completely preventable.
Completely. By giving supplemental vitamin B6, usually 10–50 milligrams per day, along with the INH, this should be standard practice for every patient on INH, especially those at higher risk like slow acetylators, pregnant women, diabetics, alcoholics, or malnourished individuals. It basically prevents the neuropathy from developing.
Such a simple fix for a potentially debilitating side effect. Finally, what about drug interactions with INH?
INH is an inhibitor of certain liver enzymes, particularly some cytochrome P450 enzymes like CYP2C19 and CYP3A4, though moderately.
So unlike rifampin, which is an inducer, INH slows down the metabolism of other drugs.
Exactly. The classic examples are carbamazepine and phenytoin, both anti-seizure medications. INH can increase their levels, potentially leading to toxicity like nystagmus, involuntary eye movements, or ataxia, loss of coordination. You need to monitor levels or adjust doses of those drugs if given with INH.
Okay, INH prodrug needs CAT-G, hits mycolic acid synthesis, watch the liver, give B6, and it's an inhibitor. Got it. Now let's move to the rifamycins. rifampin, rifabutin, rifapentine. If INH hits the cell wall, rifampin goes for the core machinery, right?
Right to the heart of replication. Rifampin works by blocking RNA transcription. It binds specifically to the beta subunit of the bacterial DNA-dependent RNA polymerase.
So it stops the bug from making messenger RNA.
Essentially, yes, no mRNA means no protein synthesis and the bacterium dies. This makes rifampin potently bactericidal against actively replicating mycobacteria, and it works both inside and outside of cells.
And its spectrum, is it just for TB?
No, it's broader than INH. It's excellent against M. tuberculosis, but also active against many NTM species like M. consacii and MSC. Plus, it hits many other bacteria, both gram-positive like Staph aureus and some gram-negatives. And it's crucial for treating leprosy, M. leprae.
It even gets used prophylactically sometimes.
Yes, for close contacts of people with meningococcal meningitis or Haemophilus influenza type B meningitis, because it eradicates carrier sates of those bacteria in the nasopharynx.
Okay, potent drug. Let's talk PK and that infamous side effect everyone warns patients about.
Pharmacokinetically, it's generally well absorbed orally, best taken on an empty stomach. It distributes widely into most body fluids and organs. CSF penetration is variable, maybe 10–20% of blood levels, but enough to be useful in TB meningitis. It's mainly eliminated through the bile into the feces after liver metabolism.
And the visible effect.
Yes. Patients absolutely must be forewarned that rifampin causes a harmless but noticeable orange-red discoloration of urine, feces, saliva, sweat, and tears.
Orange tears.
Yes. And this can permanently stain soft contact lenses, so patients wearing them should be advised. It's alarming if you're not expecting it, but it's just the drug and its metabolites.
Good to know. What about other side effects? Is it generally well tolerated apart from the color change?
Usually, yes. Common things are nausea, vomiting, or rash. Hepatitis is possible, but less common than with INH alone, although the risk does increase when they're given together, or especially with pyrazinamide.
But there's a specific issue with intermittent dosing.
Yes, this is important. Taking rifampin intermittently, like maybe high doses twice a week instead of daily, can lead to a flu-like syndrome, fever, chills, muscle aches. Sometimes this can progress to more serious complications like acute kidney injury, hemolytic anemia, or even a shock. Consistent, usually daily, dosing is generally preferred to avoid this immune-mediated reaction.
Okay, now for the really big one with rifampin, the drug interactions. You mentioned INH is an inhibitor. Rifampin is the opposite, right?
The absolute opposite, and one of the most potent examples we have in pharmacology. Rifampin is a powerful inducer of numerous hepatic cytochrome P450 enzymes, especially the crucial CYP3A4, but also others like CYP2C9, 2C19, YA2, as well as phase 2 enzymes and drug transporters like P-glycoprotein.
What does being such a strong inducer mean in practice?
It means rifampin dramatically speeds up the metabolism of many, many other drugs that are broken down by these enzymes or transported by these proteins. It significantly decreases their half-lives and their blood concentrations, often rendering them ineffective or subtherapeutic.
It's like it turns the liver into a drug-chewing machine on overdrive.
That's a good way to put it. It even induces its own metabolism, a process called autoinduction, so its own half-life shortens over the first week or two of therapy.
Give us some critical examples. What drugs are most dangerously affected?
Oh, the list is long, but some major ones include warfarin doses might need to be drastically increased, and INR monitoring becomes critical. Oral contraceptives, their effectiveness can plummet, leading to unintended pregnancies. Backup contraception is mandatory.
And the big one for co-infected patients, HIV medications.
Yes, this is a huge clinical challenge. Rifampin massively accelerates the breakdown of many HIV protease inhibitors and non-nucleoside reverse transcriptase inhibitors, NRTIs. Standard antiretroviral therapy often fails completely in the presence of rifampin. You often have to completely switch the HIV regimen to drugs less affected or find an alternative to rifampin.
This powerful induction effect basically forces difficult choices in patients on other essential medications.
Absolutely. Managing the drug interactions often dictates the entire treatment strategy, sometimes forcing you to use less potent or more toxic alternatives just to avoid the rifampin interaction.
Which brings us perfectly to rifabutin. Why does this alternative rifamycin exist?
Rifabutin is the solution primarily for TB patients who are also infected with HIV and need to be on protease inhibitors or certain NNRTIs.
Why? How is it different?
The key difference is that rifabutin is a less potent inducer of CYP enzymes compared to rifampin, maybe only 40% as potent an inducer.
So it still induces metabolism, but not nearly as much.
Exactly. This reduced induction means that the impact on HIV drug levels is much less severe and often manageable, perhaps with dose adjustments of the antiretrovirals. It allows for concomitant treatment of both TB and HIV more safely.
Does rifabutin have its own unique issues?
It shares some side effects with rifampin, like GI upset and potential liver issues, but it also has some distinct ones, like uveitis, inflammation in the eye, neutropenia, low white blood cells, and sometimes skin hyperpigmentation.
Yeah.
And it can still cause that orange discoloration.
Okay, and briefly, rifampin time.
Rifapentine has a much longer half-life than rifampin or rifabutin. This allows for less frequent dosing. Its main use currently is in that once-weekly regimen with INH for treating latent TB infection, LTBI, over 12 weeks.
So INH or pentine for LTBI, can it be used for active TB?
It is being studied and sometimes used in specific situations for active TB, particularly in HIV-negative patients with minimal pulmonary disease, maybe in the continuation phase. But daily rifampin is still generally the standard rifamycin for active TB treatment if interactions aren't an issue.
Okay, rifamycins, RNA polymerase inhibitors, potent killers, watch for orange secretions, beware the flu-like syndrome with intermittent use, and rifampin is the king of CYP induction, making rifabutin essential for many HIV patients.
That's the core message, yes.
Next up in the RIPZ quartet, pyrazinamide, PZA. This one has a unique role, doesn't it? Especially early on.
It does. Its precise mechanism of action isn't fully nailed down, which is interesting. But we know it's a prodrug, like INH. It needs to be converted to its active form, pyrazinoic acid.
And who does the conversion?
A mycobacterial enzyme called pyrazinamidase encoded by the PNCA gene. Mutations in PNCA are the main cause of PZA resistance.
And what makes pyrazinoic acid special? Where does it work best?
Its unique strength is its activity in acidic environments. Pyrazinoic acid seems to disrupt membrane function and energy metabolism, but only effectively at a low pH.
Like the conditions inside macrophages.
Exactly. It's particularly active against bacilli residing within the acidic phygallosomes of macrophages. It also works well in the acidic environment found within caseous lesions, those areas of dead tissue.
So it hits the bugs hiding out in places where the pH is low, where other drugs might struggle.
Precisely. These are often the sites where you find populations of semi-dormant or non-replicating persistent organisms. PZA's ability to sterilize these specific populations, especially early in treatment, is thought to be the main reason why its inclusion allows us to shorten the overall treatment duration for susceptible TB from 9-12 months down to the current standard of 6 months.
So PZA is the key to the short-course chemotherapy.
It's a major contributor. And since most of this sterilizing benefit against persisters happens early on, it's usually only needed during the initial 2-month intensive phase and then discontinued.
What are the main cautions with PZA?
Well, it definitely contributes to the overall risk of liver toxicity, especially when used in combination with INH and rifampin. Liver function monitoring is important when PZA is on board.
And there's another very characteristic side effect.
Yes, hyperuricemia. PZA commonly causes uric acid levels in the blood to rise because it inhibits renal excretion of urate,
Which can trigger?
a painful gouty attack, especially in patients with a history of gout. While routine treatment of asymptomatic hyperuricemia isn't usually recommended, patients should be warned about the risk, and it needs careful consideration in those with pre-existing gout. Sometimes it can cause arthralgias or joint pains, even without a full gout flare.
Okay, PZA prodrug needs pyrazinamidase, hits bugs in acidic niches, allows shorter therapy, watch the liver, and beware of gout.
That sums it up well.
Finally, in our first-line RIPE regimen, we have ethambutol, EMB. What's its role and mechanism?
Ethambutol is primarily bacteriostatic, meaning it inhibits growth rather than directly killing the bacteria, although it can be bactericidal at higher concentrations.
Yeah.
Its main role in the initial 4-drug regimen is to provide cover against potential INH resistance.
So it's there mainly as insurance in case the INH doesn't work.
Largely, yes. If the TB isolate turns out to be fully susceptible to INH and rifampin, ethambutol can often be stopped early. But having it on board initially prevents the emergence of rifampin resistance if INH resistance was present but unknown at the start.
How does it work? What does it inhibit?
It inhibits an enzyme called arabanosyl transferase 3. This enzyme is essential for the polymerization of arabinogalactan,
Which is a key component of.
the mycobacterial cell wall. Arabinogalactan links the peptidoglycan layer to the outer mycolic acid layer. So by inhibiting its synthesis, ethambutol disrupts the assembly of this crucial cell wall structure.
Another attack on the cell wall, but a different mechanism than INH.
Exactly. And it's quite specific for mycobacteria. It's mainly excreted by the kidneys, both as the unchanged drug and some liver metabolites, so the dose needs to be adjusted in patients with renal impairment.
Okay, now for the most important adverse effect, This one is really quite serious and requires specific monitoring.
Yes, we're talking about optic neuritis, inflammation of the optic nerve.
What does that lead to clinically?
It typically causes a decrease in visual acuity, blurred vision, and, very characteristically, a loss of red-green color discrimination. Patients might find it hard to distinguish between red and green colors.
That sounds potentially devastating. Is it common? Reversible?
The risk is dose-dependent and also increases significantly with renal impairment as the drug accumulates. At standard doses, it's relatively uncommon, maybe 1–2%, but the risk goes up with higher doses or prolonged use. It's usually reversible if the drug is stopped promptly when symptoms first appear.
But if you miss it or delay stopping the drug,
It can lead to permanent visual damage, even blindness. This is why baseline and periodic monitoring of visual acuity and red-green color vision is absolutely mandatory for anyone on ethambutol. Patients should also be instructed to report any visual changes immediately.
mandatory vision checks. That's a critical takeaway. Any other concerns with ethambutol?
Well, similar to pyrazinamide, ethambutol can also decrease the renal excretion of uric acid.
So it also carries a risk of hyperuricemia and potentially precipitating gout.
Yes. So during that initial 2-month RAPD phase, patients are actually taking 2 drugs, PZA and EMB, that both increase their risk of gout. Definitely something to be aware of, especially in susceptible individuals.
Wow. Okay. Ethambutol, bacteriostatic, hits arabinosyl transferase in the cell wall, mainly prevents resistance, watch for dose-dependent optic neuritis with mandatory vision checks, and also carries a gout risk.
You got it. That completes the first-line RIPE team.
And that synergy is remarkable. INH and EMB hitting the cell wall differently, rifampin shutting down replication, PZA mopping up the persisters in acidic pockets,
It's a well-designed strategy when it works against susceptible organisms.
which provides the perfect bridge to part 4, second-line reinforcements and emerging therapies. Because when IAPE doesn't work due to resistance, or if patients can't tolerate the first-line drugs.
Then we have to move to the second-line agents, and this is where things get much tougher. We're generally trading effectiveness for higher toxicity, longer treatment durations, and often less robust clinical trial data.
Right. Let's start with the traditional injectable agents, the aminoglycosides and capreomycin. These used to be mainstays of MDR-TB treatment.
They still play a role, though newer regimens are trying to move towards all oral options. Streptomycin was one of the very first TB drugs, as we mentioned. It tends to work better against extracellular organisms. For more resistant cases, kanamycin or amikacin were often used.
And capreomycin.
Capreomycin is a polypeptide antibiotic, also given by injection. Structurally different, but mechanistically similar to aminoglycosides in that it inhibits protein synthesis. It was reserved strictly for MDR-TB when aminoglycoside resistance was present.
And the big shared problem with all of these injectables?
Toxicity. Significant, potentially irreversible toxicity. 2 main types. Nephrotoxicity, kidney damage.
Which is often reversible as caught early.
Usually, yes.
Yeah.
But the bigger concern is ototoxicity, damage to the ear. This can manifest as vestibular toxicity, affecting balance and causing dizziness or vertigo, or auditory toxicity, causing hearing loss. And crucially, this ototoxicity is often irreversible and can be cumulative with prolonged use.
Irreversible hearing loss or balance problems? That's a heavy price.
It is. This requires intensive monitoring with regular hearing tests, audiometry, and questioning about balance issues. It's a major reason why regimens relying on these drugs for 6 months or more are so difficult and why all oral regimens are now preferred if possible.
Okay, moving to oral second-line options. Para-aminosalicylic acid, or PAS. How does that one work?
PAS works similarly to sulfonamides. It inhibits folate synthesis by interfering with dihydropteroate synthase. It's bacteriostatic.
It was used more commonly before ethambutol came along.
Yes, it was largely replaced by EMB for treating susceptible TB, because EMB is generally better tolerated. But PAS remains an important component in designing regimens for complex MDR-TB cases when other options are limited.
What limits its use?
Primarily, poor gastrointestinal tolerance. Nausea, vomiting, diarrhea are very common and can be dose-limiting. It also carries risks of hepatotoxicity and, interestingly, hypothyroidism, so thyroid function needs monitoring. It often comes as granules that have to be mixed with liquid, which patients find inconvenient.
Okay, another tricky one. How about cycloserine? You mentioned this earlier. It hits the cell wall again, but differently.
Yes, a unique mechanism. It's structurally similar to the alanine, an amino acid essential for building the peptidoglycan layer of the bacterial cell wall. Cycloserine interferes with the enzymes that incorporate D-alanine into the growing peptidoglycan chain.
So another way to disrupt cell wall integrity, it's orally effective, but tuberculostatic, meaning it inhibits growth. What's the major red flag with cycloserine?
Its central nervous system, CNS, penetration and toxicity. It distributes exceptionally well into all body fluids, including the CSF, which can be an advantage for treating TD meningitis. But it means its primary adverse effects are neurological and psychiatric. This isn't just mild stuff. We're talking about potential lethargy, difficulty concentrating, confusion, dizziness, headaches, depression, anxiety, psychosis, and even seizures, especially in patients with a history of epilepsy. Suicidal ideation has also been reported.
Wow, that sounds incredibly serious. What kind of monitoring does that require?
Very close monitoring. You need to assess patients' mental status regularly, watch for any behavioral changes, ask about mood, concentration. Pyridoxine B6 is often co-administered in higher doses than with INH, as it might help mitigate some CNS effects, but the risk remains significant. It requires careful patient selection and intense support.
Definitely a drug to use with extreme caution. Now, ethionamide. You mentioned it's structurally related to INH.
So it's an analog of INH, and like INH, it's a prodrug that needs activation by a mycobacterial enzyme. Its active form also inhibits mycolic acid synthesis, specifically targeting the enzyme in EA, similar to INH.
Which explains the potential for cross-resistance between INH and ethionamide.
Exactly. If resistance to INH is due to mutations in ethionamide might also be ineffective.
What limits its use? Is it better tolerated than cycloserine?
Its main limitation is severe gastrointestinal intolerance. Nausea and vomiting are extremely common and often lead to patients stopping the drug. Hepatotoxicity is also a significant concern, requiring liver function monitoring.
So GI and liver issues are the main hurdles.
Yes, though other side effects like hypothyroidism, gynecomastia, breast enlargement in men, alopecia, hair loss, impotence, and even CNS effects similar to cycloserine have been reported. It's another difficult drug to take long-term, but often necessary for MDR-TB regimens.
Okay, let's turn to some more modern reinforcements. Fluoroquinolones like moxifloxacin and levofloxacin, these have become really important, haven't they?
Absolutely foundational for MDR-TB treatment. They offer potent bactericidal activity and generally good tissue penetration. They inhibit bacterial DNA gyrase and topoisomerase phi, essential enzymes for DNA replication, transcription, and repair.
Which ones are preferred for TB?
The later generation ones with better activity against tuberculosis are preferred, mainly levofloxacin and moxifloxacin. Gadafloxacin was also used, but has largely fallen out of favor due to issues with dysglycemia, blood sugar problems.
What are the key concerns with using fluoroquinolones in these long regimens?
Well, they have their own set of potential toxicities. GI intolerance can occur. Tendinitis and even tendon rupture, especially Achilles tendon, is a known risk, particularly in older patients or those on steroids. CNS side effects like dizziness, confusion, or headache can happen.
And there's a specific cardiac concern, especially with one of them.
Yes, QT interval prolongation on the electrocardiogram, ECG. This can increase the risk of potentially fatal cardiac arrhythmias, like torsades de pointes. Moxifloxacin generally carries the highest risk among the commonly used fluoroquinolones. Baseline and follow-up ECG monitoring is recommended, especially if used with other QT prolonging drugs.
Good to know. And absorption issues.
Yes, crucial point. Fluoroquinolone absorption is significantly reduced if taken concomitantly with antacids or supplements containing divalent or trivalent medications like calcium, magnesium, aluminum, iron, or zinc. They chelate the quinolone in the gut. So dosing needs to be separated by several hours.
Okay, quinolones. Vital for MDR. Watch the tendons, watch the QT interval, especially MOXY, and mind the cations for absorption. How about macrolides? Azithromycin, clarithromycin, where do they fit in?
Macrolides aren't typically used for tuberculosis itself as resistance develops rapidly. Their main role is in treating non-tuberculous mycobacterial and TM infections, particularly the M. avium complex, MAC. They are often a cornerstone of MAC treatment regimens.
And is there a preference between azithromycin and clarithromycin?
There can be, often driven by drug interactions. Clarithromycin is a potent inhibitor of the CYP3A4 enzyme and is also a substrate for it.
So high potential for interactions with other drugs metabolized by CYP3A4.
Exactly. Azithromycin, on the other hand, is a much weaker CYP inhibitor and is less likely to cause significant drug interactions. So if a patient is on other medications that use the CYP3A4 pathway, azithromycin might be the preferred macrolide for their NTM regimen to avoid those interactions.
That's a really practical clinical distinction. Okay, finally, in this section, let's focus extensively on bedaquiline, marketed as Certuro. This seems like a real game changer.
It truly has been one of the most significant advances in TB therapy in decades.
Right.
Bedaquiline was the first drug from a completely new class, the dialloquinolines, to be approved specifically for treating MDR-TB in adults, usually as part of a combination regimen.
A whole new class, meaning a new mechanism of action.
Yes, totally unique. It specifically inhibits mycobacterial ATP synthase. This is the enzyme complex that generates ATP, the cell's main energy currency.
So it basically shuts down the power supply of the bacterium.
Exactly. By starving the cell of energy, it stops replication and kills the organism. Importantly, it seemed to be highly potent even against non-replicating or dormant persister bacilli, which makes it very valuable for achieving cure and preventing relapse in MDR-TB.
That ability to hit persisters sounds crucial. Has it allowed for better MDR-TB outcomes?
Yes, its inclusion has been associated with significantly higher cure rates and shorter treatment durations in MDR-TB regimens compared to older, longer regimens based solely on second-line drugs. It's a cornerstone of many current WHO-recommended MDR-TB treatment strategies.
But such a powerful new weapon must come with some serious warnings, right?
Absolutely. Bedaquiline carries a prominent boxed warning from regulatory agencies. The main concern is, again, QT interval prolongation. There was an unexplained increase in mortality observed in the bedaquiline arm compared to placebo in some early trials, although the cause wasn't clear and might have related to overall disease severity. Still, the QT risk is real.
So, mandatory ECG monitoring.
Mandatory. Baseline ECG and regular monitoring throughout treatment are essential. It should be used cautiously, if at all, with other drugs known to prolong the QT interval. Electrolyte abnormalities like low potassium or magnesium should also be corrected, as they can worsen the QT risk.
Any other major warnings?
Yes, liver function also needs careful monitoring. Elevations in hepatic enzymes, transaminases, have been reported, so liver function tests should be done at baseline and periodically.
And drug interactions, given it's relatively new.
It's metabolized primarily via the CYP3A4 enzyme pathway. This means that co-administration with strong CYP3A4 inducers like our old friend rifampin or certain anticonvulsants or St. John's wort must be avoided.
Why avoid inducers?
Because they would significantly lower bedaquiline levels in the blood, potentially leading to treatment failure and the development of resistance to bedaquiline itself. Conversely, strong CYP3A4 inhibitors, like clarithromycin or ketoconazole, can increase bedaquiline levels, potentially increasing toxicity risk, so caution is needed there too.
So, bedaquiline, novel ATP synthase inhibitor, game changer for MDR-TB, hits persisters, but carries a big QT prolongation risk requiring ECGs, needs liver monitoring, and crucial CYP3A4 interactions to manage, especially avoiding strong inducers like rifampin.
That's the essence of it. A powerful tool, but one that demands respect and careful management.
Okay, we've covered TB extensively from susceptible to MDR and XDR. Let's shift gears just slightly for our final section, part 5. Treating leprosy. While maybe less common in some parts of the world, it's still a significant global issue, and the treatment strategy offers unique insights.
Right. Leprosy, caused by Mycobacterium leprae, also requires long-term multidrug therapy to prevent resistance. The standard WHO regimens usually include rifampin, plus 2 specialized agents, dapsone and clofazimine.
Let's start with dapsone. Structurally, it's related to the sulfonamides.
Yes, it's a sulfone. And like the sulfonamides, its primary mechanism is inhibiting dihydroxyurate synthase, a key enzyme in the bacterial folate synthesis pathway. It's bacteriostatic for M. lepra.
And it gets used for other things too, doesn't it?
It does. It's famously used, often in combination with other drugs, for the prophylaxis and treatment of pneumocystis jirovecii pneumonia, PJP, especially in immunosuppressed patients like those with HIV. It also has some anti-inflammatory properties and is used in certain skin conditions like dermatitis herpetiformis.
What are the key adverse effects to watch out for with dapsone? There's a really important genetic one.
Absolutely critical. Hemolysis, the breakdown of red blood cells. Dapsone can cause oxidative stress on red cells, leading to hemolytic anemia. This risk is dramatically increased and can be severe and rapid in patients who have an inherited deficiency of the enzyme glucose-6-phosphate dehydrogenase, or G6PD.
So screening for G6PD deficiency is mandatory before starting dapsone.
It is considered standard practice, especially in populations where G6PD deficiency is common, like those of African Mediterranean or Asian descent. Starting dapsone in a G6PD deficient individual without realizing it can lead to a dangerous hemolytic crisis.
Okay, hemolysis and G6PD. Anything else?
Methemoglobinemia, where the iron in the hemoglobin is oxidized, reducing oxygen carrying capacity, can also occur, usually dose-dependently. Peripheral neuropathy is another potential side effect, similar to INH but less common, Rashes and hypersensitivity reactions are also possible.
Okay, now, clofazimine. This is the other key anti-leprosy drug, and it also pops up in some MDR-TB regimens now.
Yes, particularly in the shorter 9 to 12-month all-oral MDR-TT regimens recommended by the WHO for certain patients. Clofazimine is a phenazine dye.
A dye. How does it work against mycobacteria?
The exact mechanism isn't fully clear. It's thought to involve binding to mycobacterial DNA, perhaps interfering with replication, or possibly generating cytotoxic oxygen radicals through its redox properties. It seems to have both bacteriostatic and slow bactericidal activity against M. leprae and also some activity against M. tuberculosis.
It has an interesting pharmacokinetic property related to its color.
Yes, it's highly lipophilic, meaning it loves fatty tissues. It accumulates extensively in tissues throughout the body, especially fat and cells of the reticuloendothelial system like macrophages. This accumulation is slow, and it's eliminated very slowly too, with half-life potentially measured in months.
Does this accumulation allow for less frequent dosing?
It contributes to its effectiveness even with intermittent therapy in some leprosy regimens. But the major clinical consequence of this tissue accumulation is its most notable side effect.
Which is?
Discoloration. Because the drug is a reddish dye and it builds up in tissues, patients taking clofazimine typically develop a pink to brownish-black discoloration of the skin, conjunctiva, the whites of the eyes, and potentially other bodily fluids and secretions like sweat or urine.
Skin discoloration. That sounds like something patients really need to be warned about.
Absolutely essential. It usually develops gradually over weeks to months. While it's generally harmless and slowly fades over months to years after stopping the drug, it can be cosmetically very significant and potentially distressing for patients if they aren't prepared for it. Good counseling up front is critical for adherence.
Besides the discoloration, what else is fascinating about clofazimine? It has effects beyond just killing the microbe, right?
Yes, this is quite remarkable. Clofazimine possesses significant anti-inflammatory and perhaps some immunosuppressive activities. This is particularly relevant in leprosy. Leprosy treatment can sometimes trigger immunological reactions, the most common being erythema nodosum leprosum, ENL, or type 2 reaction. This is a painful systemic inflammatory condition. Because clofazimine has these anti-inflammatory properties, its inclusion in the regimen can actually help prevent or suppress the development of ENL in treated patients. It's treating the infection and potentially preventing the reaction simultaneously.
That's a really valuable dual action.
It is, though it can also cause some GI side effects like abdominal pain, nausea, or diarrhea, sometimes related to deposition of the drug crystals in the gut wall.
Okay, so clofazimine, phenazine dye, unclear mechanism, maybe deioneridox, accumulates in tissues causing skin discoloration, warn patients, useful for leprosy and some MDR-TB, and has beneficial anti-inflammatory effects preventing ENL.
A unique agent indeed.
We have certainly journeyed through an incredibly dense and clinically critical pharmacological landscape today. Mastering this requires more than just memorizing drug names. It's about connecting the dots, isn't it?
Absolutely. What's really fascinating when you step back is realizing that successfully treating these slow-growing, heavily shielded, often intracellular organisms is almost entirely contingent on managing risks and complexities beyond just killing the bug.
It's about the host as much as the pathogen.
In many ways, yes. Success hinges on managing host genetics, like the acetylator status for INH predicting toxicity risk. It hinges on proactively preventing predictable, dose-dependent toxicities, giving B6 with INH, doing vision checks with ethambutol, monitoring hearing with aminoglycosides, watching the CNS with cycloserine,
And the drug interactions?
and navigating those powerful, often catastrophic drug interactions, particularly the CYP induction by rifampin, which dictates so much of our strategy, or the QT prolongation risks with quinolones and bedaquiline that demand cardiac vigilance.
It truly is a tightrope walk in clinical practice, isn't it?
It really is.
So the elite knowledge, the mastery we aim for today, it really centers on understanding the why. Why is treatment inevitably so long? Why must it be multi-drug therapy? Why do we use PZA for only the first 2 months?
Right. And why is the patient's individual genetic profile, their kidney function, their liver function, and crucially, their entire existing medication list just as critically important as knowing the susceptibility profile of the microbe itself?
Every drug choice seems to involve a calculated risk assessment.
It does. Whether it's the first-line RIPE regimen or bringing out a toxic second-line agent like bedaquiline or an injectable, each decision requires weighing the potential benefit against the known risks, considering the monitoring capacity you have, and assessing the likelihood of patient adherence over the long haul.
And making those specific tactical choices becomes key, like deliberately selecting rifabutin over rifampin for an HIV patient to minimize that disastrous CYP induction.
Or consciously avoiding any strong CYP inducers if you absolutely need to use bedaquiline, because you know that interaction could lead to failure and resistance. This entire field is defined by managing these complex trade-offs, where toxicity management is utterly inseparable from achieving efficacy.
So, to leave you, our listener, with a final provocative thought to mull over. We talked about cycloserine. Its use for MDR-TB has that unique mechanism disrupting dealanine in the cell wall, but its use is severely limited by that significant CNS toxicity.
Right, the neuropsych effects are a major barrier.
Now, given that cycloserine is excreted almost entirely unchanged by the kidneys, and its mechanism is totally different from our other agents, what unutilized potential might lie in medicinal chemistry here? Could we potentially modify the cycloserine molecule, maybe create analogs that retain the dealanine pathway inhibition but lose the ability to readily cross the blood-brain barrier or interact with CNS targets?
Essentially trying to separate the desired antibacterial activity from the undesired neurotoxicity based on structural modifications.
Exactly. Could we engineer a safer cycloserine? Could this ancient drug, with its unique target, hold the key to developing a novel, non-cross-resistant weapon for our future battles against even more extensively drug-resistant pathogens?
That's a fascinating question. Repurposing or re-engineering older scaffolds to overcome their limitations. It's definitely an active area of research. Could an old drug provide a new defense?
Something to think about.